Steve Coe, Assistant Clinical Faculty at UCSD, Geriatric Psychiatrist. I'm also our Outpatient Psychiatric Services Director and Director for Telemental Health Program and the Community Psychiatry Training Program. The referral to psychiatry is very common. Unfortunately, there aren't enough resources to actually provide care that's required. So, for example, nationwide, there's only about 2,400 or so geriatric psychiatrists. And so even if every single person who needs our help is referred, often the referral comes late and or the family members and the patients actually can't get to one of us. It's the fastest growing age population, and obviously dementia and cognitive disorders increase with age. However, our capacity to treat them has not increased over time. And so early screening and a partnership with primary care providers is crucial. In today's session, we will be going over reversible disease processes that could often come across as being dementia and might be picked up during the screening process. Just because an older patient or a family member says that they're having memory issues doesn't necessarily mean that they're going to go on to develop dementia. Because a lot of other medical illnesses could actually mimic symptoms of dementia. For example, a common psychiatric disorder of depression and anxiety could mimic symptoms of dementia for various reasons. One, it's well known that patients with depression actually has decreased memory recall, decreased attention, and inability to actually make a good cognitive assessment of what's going on around them. And so you can imagine if someone is elderly and they have depression, which is quite treatable, if they then complain of memory issues, it's incorrect to just automatically assume that it's Alzheimer's. Additionally, as the population ages and they encounter a lot of different medications, polypharmacy and medications that's not related to dementia that they happen to be on, be it for blood pressure issues, diabetes, etc., those things could also cause symptoms that mimic dementia. Additionally, substance abuse, particularly pain medications, as well as alcohol and other substances come into play. It's well known that alcohol use, especially heavy alcohol use, would decrease ability for memory recall, decision making, and even being alert and oriented to surroundings around them. And so if you're not assessing for alcohol use, for example, then you'll make an incorrect diagnosis about dementia. There are other factors as well, including dietary issues. A common test that we often run is B12 vitamin deficiency, because a deficiency in that crucial vitamin will actually cause memory issues and cognitive deficits that mimic symptoms of Alzheimer's and dementia. Other factors that one needs to keep in mind is often mistaken entity of delirium. Delirium is very important to assess and to treat early because if missed, it could actually cause mortality as much as morbidity is concerned. The reason for that is early symptoms of delirium, which can be caused by treatable illnesses like pneumonia or urinary tract infection. When a clinician misses that diagnosis, you intervene too late, and so then you often then could cause irreversible damage to the brain, and that's something that you want to try to avoid. And so you want to make sure that what you're seeing isn't an onset of delirium, but in fact dementia. And so a lot of these factors could actually mimic symptoms of dementia, and so it's advisable that we actually do a very thorough screening and follow-up evaluation to make sure that what we're truly seeing is dementia. So CBC or complete blood count, what that actually shows us is whether or not there's other organic issues going on that's causing cognitive deficits. For example, infections or malignancy that often isn't screened. Any type of infection which could then lead to other tests like urinary tests or other type of infectious sort of testing could tell us quite a bit. I mean, it tells us that that perhaps there's another reason as to why their memory and cognitive ability has gone down. A complete metabolic panel is important because it not only gives us an overall sense of how a patient is doing, but different measures will tell us their fluid level, whether or not they're adequately hydrating, adequately being taking in nutritions, and whether or not these other electrolyte imbalances could affect their memory and cognitive factors. So we like to check that on a routine basis. Another test that we often check for is TSH, or thyroid stimulating hormone check. We often do that because, one, it's a very treatable aspect of memory issues. And when the thyroid level goes down, which is relatively common, what happens then is that memory and cognitive ability goes down, and it's very quickly treatable. And so we like to assess for that in the very beginning. Once you get the baseline tests, including CBC, comprehensive metabolic panel, TSH, B12, etc., what you want to do is you establish as a baseline, and as you continue to follow the patient, it's recommended that you repeat the test in about 6 months to a year. It depends on the circumstances of the patient. So if they have other medical issues going on, I generally would then ask for a repeat within 6 months. If they're relatively stable, and in that initial screening, it's determined that there isn't large warning signs of a start of a dementia illness process, then you repeat it in about a year. This is usually done because dementia and memory issues are a progressive progressive illness, and so over time the patients will actually show different symptoms depending on where they are. And so it's incorrect to say that you just do one test and then you leave it at that. You actually want to repeat it on a regular basis.